Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. Welcome to Cardiology Landmark Trials. In this presentation, we are going to be looking at the Augustus Trial. This trial was based on antithrombotic therapy in patients who are undergoing percutaneous interventions in the setting of an acute coronary syndrome and atrial fibrillation. As you are very well aware of, atrial fibrillation poses a great challenge in terms of managing antithrombotic therapy in patients with ischemic heart disease who have undergone coronary interventions, who also need to be on antiplatelet agents. The antithrombotic agents that we use for preventing blood clot formation and emboli in patients with atrial fibrillation doesn't work that well in preventing thrombosis on the arterial side, while at the same time the agents that we use like P2Y12 or aspirin in patients with PCI does not very well protect people from getting deep venous thrombosis or intravascular thrombosis leading to embolization. In order to address this, there are several studies that have been done in the past. First one looked at warfarin and antiplatelet agents in the WOEST study, WOEST trial. There was another study looking at rivaroxaban with antiplatelet agents in Pioneer Afib Pci trial. The third study involved dagabatron with antiplatelet agents in ReDual Pci trial. And in all these patients, there was a challenge of atrial fibrillation in the presence of ischemic heart disease where these patients had undergone PCI. This trial looked at Apixaban and its effectiveness in treating patients with atrial fibrillation in the presence of a coronary intervention where they require antiplatelet agents. This was a multi-center, 2x2 factorial, randomized, controlled trial involving more than 33 countries. They were divided actually into two main groups, namely the population receiving Apixaban and the population receiving vitamin K antagonists. And all these patients received a P2Y12 inhibitor. In 92% of these patients, they received clopidogrel. The blinded medications included aspirin and placebo. There was a total of 4,614 patients. The study duration was 180 days or 6 months. The mean age of this population was 70.7 years, with 29% of them being female. 36% of these patients had diabetes, and all these patients had undergone recent coronary intervention, and all these patients were on P2Y2 inhibitors, and as I said, 92% of the time they were receiving clopidogrel, 75 milligrams daily. There were several main objectives in this study. The first one was to see that Apixaban was non-inferior to warfarin in terms of treating patients with atrial fibrillation in the presence of coronary artery disease. The second point was to see if there was any superiority of Apixaban over vitamin K inhibitors in patients with PCI with atrial fibrillation. The groups were divided into two main groups, namely Apixaban and vitamin K. There were 2,306 patients in the Apixaban group, 2,308 patients in the vitamin K antagonist group. This had to be assigned since patients receiving vitamin K antagonists had to have blood tests and to maintain an INR between 2 and 3. They were further blindly divided into two groups. This is after the fact. They received aspirin or placebo. This group received aspirin or placebo, which was blinded during the study. Now let's look at some of the exclusion criteria. Those patients who had mechanical heart valves, those people who were on anticoagulation for deep venous thrombosis or mitral stenosis, with those patients who had intracranial hemorrhage, patients with renal insufficiency, a patient who had been planned to undergo coronary artery bypass surgery, those patients who had coagulopathy, or there were contraindications to the study medications. 92% of them were white. The creatinine level was 1.5 in about 8% of the patients. Of course, CHAD-S-VASc score was 4.0. Stroke, transient ischemic attacks, and thromboembolic events were noted in 14% of the patients. As I said, 92% of these patients received clopidogrel. Acute coronary syndrome as a qualifying event was noted in 2/3 of the patients. And the pro time in the therapeutic range in the patients who were receiving vitamin K antagonists was in the range of 59%. 59% had an INR therapeutic range between 2 and 3. And here are the results. Primary outcomes: vitamin K antagonists and Apixaban. Apixaban clearly showed there was a significant decrease in major bleeding compared to vitamin K antagonists, with a p-value of 0.001 for non-inferiority and a p-value of 0.001 for superiority. Obviously, Apixaban was superior to vitamin K in this patient population in terms of reducing major bleeding complications. And here, looking at aspirin versus a placebo in terms of bleeding, obviously placebo had a significantly lower incidence of major bleeding compared to the aspirin group, and the p-value of 0.001. And when you look at all these four different groups, vitamin K and aspirin had the highest rate of complications, namely bleeding, hospitalizations, and death, compared to Apixaban with placebo, which had the lowest incidence of complications. So there is a clear dichotomy between these two groups. The Apixaban, along with a P2 Y12 inhibitor and placebo, had a much better outcome compared to those patients who were treated with P2 Y12 inhibitor along with vitamin K antagonist and aspirin. This is where the risk was. Now let's look at death and hospitalizations. There was a modest decrease in the number of deaths and hospitalizations among the Apixaban group compared to the vitamin K antagonist group. Similarly, in the aspirin and placebo group, the death and hospitalizations, there was a modest reduction in the placebo group compared to the aspirin group. So, in terms of bleeding, in terms of mortality and hospitalizations, aspirin proved to be more risky than the placebo. And when death and hospitalizations were looked at, again, Apixaban and placebo had the lowest incidence compared to vitamin K antagonist and aspirin. Stent thrombosis was noted in 1.6% of the group, 80% of them happening within the 30-day duration. In conclusion, aspirin in the first 30 days in the aspirin treated group, in the first 30 days, there was increased bleeding with a slight reduction in severe ischemic events. Whereas beyond 30 days, there was more incidence of bleeding with aspirin compared with placebo, and the incidence of ischemic events was not much different. As far as Apixaban is concerned, in patients undergoing PCI, Apixaban along with P2Y2 inhibitor resulted in lower bleeding compared to those patients receiving P2Y2 with vitamin K and aspirin, and it also reduced death and hospitalizations. So, ladies and gentlemen, thank you so much for watching this presentation, and please stay tuned for other cardiology landmark trials on our YouTube channel, and please do subscribe to our YouTube channel, and we will see you next time. Thank you.